The proceeding will start shortly. 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 The proceeding will start shortly.
Order, order. Welcome to a special session of the House of Commons Health and Social Care Select Committee. With us this morning we have Professor Chris Whitty, the Chief Medical Officer, Dr. Thomas Waite, Interim Deputy Chief Medical Officer for England, and Dr. Susan Hopkins, Chief Medical Advisor for the UK Health Security Agency. We're also pleased to welcome Greg Clark, Chair of the Science and Technology Select Committee, joining as a guest panellist. Thank you all very much for joining us at a very busy period. Let's get cracking right away, if we may, Professor Whitty, and just I want to give you a chance to elaborate on what you said yesterday. You said that we should prioritise social events that matter and deprioritise more trivial ones. In practical terms, could you explain what you meant when it comes to people thinking, for example, about their Christmas plans?
Thank you, Chair. So I hope what I was said was reasonably clear, but I'll try and phrase it slightly differently and see if that helps. I think everybody can see this is moving very fast and this is highly transmissible, and the rates are going to continue to go up. It's a period of the year when lots of people have got things that really matter to them, family-wise, also in other bits of their life. And my point was, and I hope I can reiterate this, that people want to protect the time that is most important to them. And that does therefore mean, in practice, it is sensible for people to cut down on work or other interactions with people, including potentially social ones, which are less important to them, so that they reduce their chances of catching COVID and indeed reduce their chances of passing it on. I wouldn't want to say to people that they should do a particular thing, they should do this or they should do that. This is about saying to people, look, this is a period to prioritise. And that also, to be clear, was a message the Prime Minister also said last night.
So just to be a bit more specific, Dr. Nikki Kanani yesterday advised people not to go to football matches if it was to watch football. Do you agree with that?
What she was actually saying was, if someone went to a stadium, please make it an opportunity to have a boost. And I think that's a message we really seriously want to get to. Obviously, we want to get back to a situation where we're back on a more normal track, and the route to that lies through the booster program. And what she was saying is, we are opening up stadia over this weekend for boosting, and her positive message, as someone very heavily embedded in the boosting program, was please take your opportunity to get boosting, and if that means going to a stadium, that really should be the priority.
But you're not advising people not to go to football matches, correct?
What I'm advising people to do is to prioritise. If the most important thing to them in the next 10 days is to go to a football match, that's the priority for them. That's really the point I was trying to make. But prioritise the things that really matter to you, but don't. But if you wish to do those things and wish to do so and not end up self-isolating or unwell at a time you really don't want to be, then you're probably going to want to do fewer other things.
So if you were planning in the next week to go to, I don't know, 4 or 5 social functions, your advice would be try not to go to perhaps the 2 or 3 that matter least to you.
Well, certainly, I mean, it would obviously depend what other social, basically what I'm saying is that anybody who has something that really matters to them, concentrate on that thing and then build out from there, rather than just accepting every invitation and going to every bit of work in person. And this very much applies also to work situations. Certainly our team are way down in terms of the numbers coming in, that's quite right. Most other teams are that I know, and that's very sensible. Government guidance is work from home if you can, and that absolutely remains the guidance now.
Just to be more specific on something that's going on a lot at the moment, which is Christmas parties and office Christmas parties, I think what you're saying is that if you're one of those people for whom that kind of party is not essential as compared to spending time with your family, for example, then that would be a good thing not to go to.
Yeah, I'm really trying to avoid, and you're trying to make me, but I'm still trying to avoid making other people's choices for them. But I would go on to say really clearly that I think people should prioritise what really matters to them and then cut down on the things that don't. For some people, it may be that what really matters to them is going to the office party, fine. But I think it really should be really for people to make those choices.
That's very clear and helpful. Thank you for that. Can I just move on to some more questions about Omicron itself and what we do know and what we don't know? Now, one of the things that you talked about that we don't yet really have hard data on is the extent to which vaccines will stop you getting seriously ill. So far, as I understand it, the studies seem to show quite a lot of vaccine escape after 2 doses, but much less after a 3rd booster dose. Could I ask, do those figures relate to antibody deterioration and T-cell deterioration, or is it just antibodies?
So there are 2 lines of evidence. There's the lab side of things and there's the clinical side of things. And for all of these, and I know you know this, Chair, but I'm laying it out for people watching this, there are kind of 3 things we're interested in. The ability of the vaccine to stop people getting infected, the ability of the vaccine to stop people getting severe disease and ending up in hospital, and the ability of the vaccine to stop people dying. And in general, they get more and more effective as you go up that line. Now, what we have at the moment on the lab side is quite a lot of different labs looking at the antibody data, which is half of the immune system, as you imply, and that certainly suggests that antibody response is much less effective against this variant than it was against Delta and Alpha and the original Wuhan strain. Now, that doesn't necessarily, that is likely to translate into reduced ability to reduce infection. And that is indeed what we're seeing. So the clinical studies are showing that lots of people are getting reinfected with Omicron who previously had been vaccinated or had a combination of vaccines and natural infection. So it definitely is likely to bypass some of the ability to reduce infection. What we don't have is very good T-cell studies in the same way as we do, because they take longer to do, for one thing, from the lab side. What we don't have is clinical studies, either from South Africa or the UK or indeed anywhere else, that say to us with confidence what the level of protection of 1 dose, 2 doses, and a booster dose are on hospitalization and deaths. Now, I think most people think on the positive side, we all think that there will be some preserved immunity, particularly on the non-antibody side, T cell and other side, and therefore it is likely that someone who's had 1 or 2 vaccines already will have some protection, and with a booster, considerably more protection against hospitalization and death, even though the protection against infection is less good. And the final point I want to make on the boosters is it does look as if they restore some of the ability to actually reduce infection, probably quite a lot of it actually, at least for a period of time. And so there are multiple reasons to get the booster. It will reduce your risk of severity, it will reduce probably the risk of mortality, and it almost certainly will reduce your risk of transmitting and getting symptomatic disease. So we really want to push the point that boosters is absolutely critical to this.
When do you think we will get good data on hospitalization rates and risk of severe illness and death?
I think we'll get some reasonable data from South Africa before we do from the UK, but that will be for 2 doses because they haven't got a booster program in the way that we have yet. And they will probably go first on the clinical side, but there's good data coming here. And I'll ask Dr. Hopkins to talk about that because UKHSA, and indeed specifically Dr. Hopkins herself, are leading on this. In terms of the booster, that will take longer, obviously, because as of 2 weeks ago, almost nobody was boosted. And now we've got really good levels in the older population, but we haven't yet got all the way down to the group which is actually being infected by Omicron. Susan, do you want to add to what I've said?
Yeah, so we have a series of studies that we have planned and have the analysis all ready to run. What we know is that we need about 250 individuals in hospital before we can make a severity assessment compared to Delta, and also a vaccine effectiveness assessment. We start running that assessment when we start having enough cases who have been admitted to hospital to do it, and then we run it daily until we have enough power to determine that the results are effective to allow us to basically make assessments to release.
And how many Omicron patients do we have in hospital as of today or yesterday?
So the released numbers that we released yesterday are 15. However, we are constantly working on data linkage to improve that, and we will release new numbers this afternoon.
But the real number will be much bigger than that. That is simply the number who are proven, just to be clear.
Yeah, exactly.
Understood. But just to give us all, as members of the public, an idea of timescales, are you expecting to have some reliable data before Christmas, in a week's time, or is it going to be January before we really know the answer to that question?
I think the earliest that we will have reliable data is the week between Christmas and New Year, and probably early January.
Okay, thank you. Let me move on to another question, if I may, Professor Whitty, which is about transmissibility. Now, there's been a lot of discussion about the doubling rate being 2 days or even less than 2 days. Obviously, mathematically, that would mean that within 2 or 3 weeks, the entire population would be infected. Is that what you expect to happen, or would you expect the doubling rate to slow down as the infection progresses?
So I think that the doubling rate will slow down for 2 reasons. The first is that people are taking sensible precautions. It's very clear they're taking sensible precautions, and that itself will help to slow the doubling rate down. And the points we were making about prioritising the interactions that matter to most of you, the government's advice on working from home, they're all designed to help slow this down, particularly at the beginning, to buy us time to get through the boosting. And then at a certain point, the number of people who have already been infected and have got immunity, either from the boosting or from Omicron itself, will mean that the group of people it can now infect is getting smaller, and that will also slow it down. And at a certain point, that reaches a peak. I think what we will see with this, and I think we're seeing it in South Africa, is that the upswing will be incredibly fast, even if people are taking more cautious actions as they are. That will help slow it down, but it's still going to be very fast. It'll probably therefore peak really quite fast. My anticipation is it may then come down faster than previous peaks, but I wouldn't want to say that for sure. I'm just saying that that is a possibility. But in terms of where we're going over the next couple of weeks, the rate of increase is going to be, I think, fairly impressive.
Okay. Let's just talk about that peak for a moment. So the London School of Hygiene and Tropical Medicine, which advises SAGE, say they expect that over the winter months 20 to 30 million Brits will be infected with Omicron. It'll peak at around 600,000 infections a day around the end of January. Hospitalizations between 3,000 and 7,000 a day. Is that your central expectation as well?
I have to admit that I'm extremely cautious of forward projections on exponential models. If the London School, this isn't the criticism of the model, to be clear, the problem is that even a very small change in the inputs you put in leads to a very big difference in what you get out at the other end. And there are some really critical things we don't know. We obviously don't know at what level it's going finally to peak. We don't know that yet. And we do not yet know what the effects in terms of hospitalizations of 2 doses of vaccine, of prior infection and of a booster dose are. And there is still debate about, could this be a slightly milder version? I don't think it's to the point of actually triviality, but it's just, and all of these are really important. So I'm very careful, and I've not all the way through the whole pandemic, I've resisted putting forward projection numbers, except over a very short time period where I think it's more reliable, into public domain, simply because I don't think they're reliable and you can't put enough caveats on them.
Okay. But let's look at the numbers we do know. We do know yesterday was the highest ever daily reported level of infections. You said you thought we might end up, because of the time lag to hospitalizations and deaths, we could end up with a record number of hospitalizations at a daily rate as well. We don't know, but we could do that. The general view is that the NHS starts to really struggle if they have to cope with more than 4,000 in a day, and I think the previous peak in January was 4,500.
Yep.
Do we have to confront the realistic possibility, even likelihood, that 4,500 previous maximum will be exceeded?
So I think that there are several different bits to this, and of course we're talking about huge uncertainties. So I don't want this to be seen as I'm saying this will happen. I'm just saying there's a range of possibilities. But certainly the peak of just over 4,500 or 4,583 to be exact, people admitted at the absolute peak, it is possible, because this is going to be very concentrated, that even if it is milder, because it's concentrated over a short period of time, you could end up with a higher number than that going into hospital on a single day. That is entirely possible. It may be less than that, but I'm just saying that is certainly possible. And the whole point about this is it's going to be really concentrated in a very short period of time, very possibly. There are 2 caveats to that, however, because one of the things that really matters to the NHS is also how long people stay. And if, for example, people stay in hospital for a shorter period because they're protected by prior vaccination, that means that the total number could still be lower, even if the peak number per day is going up is higher. So the peak total number of inpatients was about just under 40,000, 39,254 rather, to be exact. It could be you could have a higher daily rate, but a lower inpatient rate if there's a shorter hospitalization. Obviously, it could go the other way as well. And the other thing is that the number going into ICU could also be quite a bit lower if, in addition to protecting against hospitalization, vaccines provide additional protection against really severe disease. So I think what we shouldn't assume is that if we got the same number going in the front door, that necessarily translates into the same numbers in hospital and in ICU at some point in the new year.
Okay, so we had that previous peak in January, and what we did then was we controlled it by locking down the country, and that brought that number down. Have you advised the government that we need to be doing more now than we're currently doing to reduce the spread of Omicron?
I'm going to give a formal answer, and then I'll try and give a slightly more helpful one. But my formal one is the only formal advice is what comes from SAGE on the science side, and that is published. And it's very important that we don't start saying this is what we say to ministers on this, that, the other day. There will be a public inquiry, they'll go through those. But other than that, the convention is, and obviously as a distinguished previous Secretary of State, you would have expected the same, that advice to ministers is absolutely confidential. But what the government has said, and I think what we have all said, is to make really tough economic and social decisions, there are some really key bits of information we do not yet have. And there's a very wide range of possibilities as to where this could go, some of which are, as you imply, very difficult for the NHS indeed, and some of which are much less so. And we're getting new information the whole time. So this is being reviewed by the government the whole time, but they've got a clear plan of action. Ministers have set out a clear plan of action, which is has two strands, one of which is around working from home, plan B things, all the things to try and slow things down at this initial stage of the upswing, and the other, really critically, is the booster programme. But obviously, if the facts change and it becomes clearer things are heading the wrong way, ministers are always going to take constant reviews of this.
Well, that's what I really wanted. That's helpful. What I really wanted to understand is, in terms of setting expectations. I appreciate you can't tell us about every detailed conversation that you have with the Prime Minister, but in terms of setting expectations at the moment. Theatre performances, Christmas parties, football matches are all going ahead. But if things continue to take a turn for the worse, we need to be prepared for that to change. Is that what you're saying?
I think that if it looked as if the vaccines were less effective than we were expecting, I think that, for example, would be a material change to how ministers viewed the risks going forward. Can I just add one risk which is going to happen irrespective? And that is that because of the steepness of this, even if this ends up in a situation where boosters do hold this to a large degree for a lot of people, there's still a lot of people in the NHS, so this is not an NHS point, however, a lot of people will simultaneously fall ill and be unwell, isolating or caring for others at the same time across the whole economy. So that side of things I also do think we need to take quite seriously.
Thank you. Luciana.
Thank you, Chair. Professor Whitty, you've been very clear that COVID will be with us for a long time, if not forever. In the event of more variants of concern, is it your view that we will have to continue to live with reduced social contact, deprioritisation, in your words, for years to come?
So I think the way that I'll try and explain the way that I see this over kind of a long time period, meaning kind of 5-year frame, because I think that is a really critical question you just asked. If I project forward, I would anticipate in a number of years, possibly 18 months, possibly slightly less, possibly slightly more, that we will have polyvalent vaccines, which will cover a much wider range. And we will probably have several antivirals. We've already got 2 reasonable ones, and a variety of other countermeasures that mean that the great majority, and probably almost all, of the heavy lifting when we get a new variant, unless it's extremely different, can be met by medical means, because the vaccines have wider coverage and the antivirals pick up some of the remaining slack. And we've come from a place where we had absolutely nothing. So everything had to be done by social distancing and all the destructive things that went with that right at the beginning. Where we are at the moment is in a transition period. A very large amount of it can be done by this, and this is why the boosters are so absolutely essential. But we're not quite in the rather safer haven I expect we will have in a couple of years' time. So I don't see this as a kind of we're going to have to do this repeatedly every few months situation. I do see this as something where we, as I say, we're in this transition. And how we're responding to this variant is very different to how we would have responded in a pre-vaccine era. So that's an example of how I think things are going to change, but that change will continue.
So potentially that transition period could last several years. Is that what you're saying?
I think what will happen is the risks will gradually decrease over time. It's incremental, it's not a sudden thing, but I think each 6 months will be better than the last 6 months. How fast that will be, it's always dangerous to predict science, but I think what's been impressive about this from a scientific point of view is that actually my expectations have been surprised on the upside all the way through on the science thing so far. We've had faster vaccines, faster clinical trials, faster new drugs than I would have predicted at the beginning of the epidemic, and in fact than I did predict at the beginning of the epidemic. So it may, my job is to try and give a cautious central view. It could be slower than that, but actually there's a possibility it could be faster than that. But I do see a future which is much less risky than it is at the moment, and as I say, it's less risky now than it was 6 months or a year ago.
Yeah. So you foresee a situation where we will be learning to live with COVID as we do with, say, flu, and that is the longer-term plan. Is that right?
Yes, and I think that's how we've dealt with every single major infectious disease. And I think if you look historically, one of the things medical science has been most effective at is every time it's been faced by a really major infectious threat, we have found a countermeasure, including ones that came from really odd, the last really big pandemic, very different one was HIV. The approach that we took to that was obviously completely different, but we now have medical countermeasures to it. So I do actually think, yes, in the future, in the long run, science will de-risk this to the point. It's not going to go away as a problem. It'll always be a problem. Some years it'll be a big problem. And the way I would see this with COVID at the moment is this is rather like a kind of high hairpin bend that it's been put in our way. We were cruising along at a reasonable speed. We've now got to slow right down. We've got to go round it. We've got to actually get ourselves back on track with the boosters, and then we can kind of accelerate out again. So that's really, and what we hope is that we'll get less and less needed as the medical countermeasures mount up.
Thank you. Thank you, Chair.
Barbara Keeley.
Thank you, Chair. I want to ask some questions about pressures on social care, given the link to NHS capacity, and just some points for context first. Amanda Pritchard and Stephen Powers wrote to NHS leaders to encourage discharge from hospital by avoiding the need for social care support through personal health budgets and hotel beds. Now, reports of hotels being turned into temporary care facilities in Devon have horrified patient groups. Nadra Ahmed from the National Care Association said that hotels are not configured to deliver care and questioned the safety and well-being of residents if they needed urgent medical assistance. Do you think people can be cared for safely in hotels, and is this a proportionate measure to take in the context?
So I want to start this by saying that I'm not responsible for the operational side, and I don't want to try and start making out NHS policy on the hoof. What inevitably you have is a situation where, as with all emergencies, you're doing the least bad thing that you can do, which is still going to be far from perfect. And many of the decisions we've had to take in the health service and the social care system have been things we would never want to do under ordinary circumstances, but they are less bad than the alternative. And if the alternative is a situation where people are stuck in hospitals exposed to all the risks of that, and where the hospitals, as a result of that, with people who could be medically discharged, there are people queued up in ambulances outside with life-savable conditions, but life-threatening conditions. That's clearly even worse than any of the alternatives. But none of us would see this as a perfect solution. This is a situation you want to have for a period. Now, of course, there are some people who can be cared for in a hotel setting where actually it's simply a matter of just waiting for them to have a placement. So for some people, this is absolutely fine. What the job of the clinicians will be is to try and make sure as best they can that the people who are least at risk are the ones who end up going into hotels or similar kinds of things, and the ones who are more at risk stay in hospital until such time as they have a placement which they can move to. But this is a matter of the perfect being enemy of the good. We've got to just accept this is a very difficult period. It was always going to be difficult. Omicron has made it even more difficult. And we are going to end up with some compromises which are not things we would normally wish to do.
Okay. I think it's quite important that we talk about this, and there's a danger of repeating past mistakes. I remember in evidence that you gave to us last year, Professor Whitty, that you said it's clear every country that has a care sector has not handled this well. The UK is one country that hasn't handled it well in terms of the issues in social care. Now, we said at that point of the inquiry that there are a lot of things that we've learned and that we can do a lot better. But you did say, I don't think any of us would look back on what has happened in social care and say the ideal advice was given. Yep. How do you think the mistakes of last year's discharge policy can be avoided this time around? And importantly, if I can just add to that, who is advising ministers on the care sector and safe discharge? Because the advice wasn't very good last year.
Well, I'd like to sharply draw a distinction between the discharge policy, which actually was a bit more complicated than it's sometimes portrayed, and was not what I was talking about. I think actually the discharge policy was, in many situations, a safe policy, but I'm happy to come back to that. But that's old, in a sense, that's an old debate. I think we're looking forward to a new set of threats.
Indeed, it's just not repeating the mistakes that were made before.
Okay, I just wanted to be clear that I didn't want to kind of, But I completely agree. So there are several mistakes that we made, which I'll just give a couple of examples, which I think we're not doing now. The first mistake we made was I don't think we were fast enough on cutting down on people working between care settings rather than staying in one particular one. That was absolutely essential. I think we didn't spot the effects of people not having adequate sick pay until, which was an obvious point. It's one of those things that's obvious when you see it, but actually we just haven't seen how much that was driving things. There are several others which are things which I think we'll need to come back to, but we haven't, in my view, repeated those mistakes this time around. We've learned a lot from previous events. The most difficult decision at the moment for Omicron is how do we balance the needs to allow families and very close friends to see people in care, I'm talking particularly in elderly care, against the need to reduce the risk of this incredibly infectious infection getting in particular before we got everyone boosted and their immune system responding. That's a really difficult trade-off, because what we don't want is a situation where over the Christmas period people are left completely alone, but nor do we want to have outbreaks we can avoid, and we're trying to navigate a route between those two very clear needs. That's probably the most difficult decision at this point in time.
A further question that affects capacity. I don't know how aware you are of the workforce crisis in social care, but using personal health budgets, as has been suggested as part of discharge, relies on there being staff to be employed as personal assistants, available to take on that care. The current situation has been described as the biggest recruitment crisis in social care that anyone can remember. Not only is that the case, but care providers are reporting that government funding allocated for the recruitment crisis is not making its way past local authorities to them. So that, you know, take any temperature on that, and it's very difficult. Do you think the very limited capacity and the workforce issues in social care will significantly limit how many patients can move out of hospital beds into the community? And, you know, do we need to think about what measures can be taken to deal with that if it is the case? Because it seems to me this week that is the case.
Well, I think I need to be very careful here. My job is to answer questions that only a doctor can answer. This doesn't strike me as one that's a doctory question, really. But I will give an answer as best I can, because it is very important for the management of the situation. There is a very serious issue with recruitment into social care, and I think that is widely accepted. And the difficulties of the social care system are long-standing, and long-standing over many years. This goes back over more than several administrations. So this is not a kind of here and now problem. This has been a long-term issue. I think there have been several recent serious attempts to look, including under indeed your distinguished chair, to look seriously at what we can do to improve the situation in social care. I don't think I'm the right person really to give a view on that. I'm just acknowledging the question you're asking is a very sensible question. I'm just saying I'm not the right person to answer it.
Okay, thanks.
Thank you. Dean Russell.
Thank you, Chair. Professor Whitty, you'll know that this week has been quite a debate about the introduction of the Plan B measures, and many people voted, myself included, to vote those through based on data and on insights and on predictions that were given by yourself and other colleagues. I just wondered if I could ask you a few questions now on some of that data and some of the questions I've heard since that time. One of which is whether you could share the percentage of positive cases against the number of tests being reported, and whether moving forward we will begin to see those trends more public.
So on positive tests versus tests reported, I'm going to turn to Dr. Hopkins, because this is a UKHSA issue.
Thank you. So we report NHS test and trace statistics on a regular basis, the number of tests reported positive from each of the channels that are there. So home testing channel versus on-site testing versus adult social care versus, and look at lateral flow. And we can see that there's a very big variation in those. Walk-in testing usually has the highest test positivity because those people are symptomatic. For example, adult social care has very low positivity because actually what we're doing there is testing people who are well regularly and repeatedly to avoid infections coming in. So that data is produced on a weekly basis as forms part of the traditional NHS test and trace statistics. And again, we do report the number of tests performed on a daily basis on the coronavirus dashboard, and also the number of positive individuals.
And if I may ask on that, so one of the comments that I've heard is that because we're now testing right down to children aged 5, for example, that the chances of having a higher rate of infections is going to go up because the sample data is higher. Is that a fair thing to say, or is that skewing the data?
So firstly, I mean, we release on our weekly reports age testing rates and also positivity rates by children of all age groups. We have always tested young children who have had symptomatic disease. The only change in the advice that's come out this week is that daily testing, if you're a contact, will go down to as children as young as 5 to reduce transmission in schools.
And in terms of, and perhaps if I could come back to you, Professor Whitty, one of the other comments that I've heard is that people are concerned that we're prioritising COVID over other things, and especially with the Omicron variant. You know, COVID over cancer, COVID over other serious issues. What would you say to that?
Yeah, I think this is sometimes said by people who have no understanding of health at all, but I don't think it's said by anyone who's serious, if I'm honest. And when they say it, it's usually because they want to make a political point. The reality is, and if you ask any doctor working in any part of the system, they will say this, that what is threatening our ability to do cancer, what is threatening our ability to do all these things, is the fact that so much of the NHS effort, so many of the beds are having to be put over to COVID, and that we're having to work in a less efficient way because COVID is there. Finding a way to manage COVID in a way that it minimises the impact on everything else is absolutely central to what we're trying to do. And in a sense, I completely agree. There are multiple other things in addition to COVID. If we don't crack COVID at the points when we got big waves as we have now, we do huge damage elsewhere. And the idea that the lockdowns cause the problems of things like cancer is a complete inversion of reality. If we had not had the lockdowns, the whole system would have been in deep, deep trouble, and the impact on things like heart attacks and strokes and all the other things people must still come forward for when they have them would have been even worse than it was. So I do want, through all of you, to make absolutely clear that's an inversion of reality.
That's an excellent answer, thank you. And may I just, very last question, is just, I know one of the concerns I've had through is about Omicron and the impact on children. Have we got any more evidence now about what impact there could be that's different from, say, the Delta variant?
That's a really important question. At the very initially, some of the South African data did imply that there might be a slight increase in the number of children getting it compared to previous waves. Still nothing like many of the other infections, which are primarily infections of children. Actually, as the data have gone on in South Africa, and for what it's worth, in our early experience in the UK, we're not seeing that develop. So I think at the moment, my view, too early to be sure, but I don't think there's anything that's saying we should change our advice in terms of the relative risks for children. Now, the total number of people infected with this over a short period is going to go up. So some children, a lot of children will get it, and a very small number, hopefully, will get into trouble as a result of it, because this is not a trivial disease, but it is much, I think we would still stick to the view that this is much milder in children than in older adults.
Thank you. Thank you. Sarah?
Thank you, Chair. Professor Whitty, I've got two topics for question. One of them is pregnant women and the other one is new variants, so I will get started straight away. In August, only 22.2% of pregnant women were vaccinated, yet 1 in 6 of the most critically ill patients are unvaccinated pregnant women. What should the government be doing to increase the take-up, and was it a mistake to not include pregnant women in priority vaccination groups sooner?
So on the first of those, I completely agree with the point you're making, and the uptake of vaccination in pregnant women is depressingly low, and as you say, significant numbers of women have come to serious harm as a result of this. Almost all the women who are in hospital or in ICU with this are people who have not been vaccinated. So vaccination really protects pregnant women, and pregnancy is a period of vulnerability. I think that we really should have made that point even clearer earlier on. This isn't a government point, this is a medical profession point. Of course, obstetricians, people like me have said it. I've said it several times publicly. The chief scientist here in the department, Lucy Chappell, who's an obstetrician herself, has said it. We've all tried to say this very strongly. I think that there are a lot of myths around this, and this is the thing we really need to take on. is we need to say, look, it is not true there are increased risks of this vaccine. What is true is that COVID and pregnancy is a dangerous combination. And we absolutely should be encouraging everybody who is pregnant to get vaccinated, because that helps protect them and that is in the long run interests of their baby and their future. So I absolutely agree it's a serious problem and everybody should be doing everything they can to increase that. In terms of the change of emphasis, I mean, I think JCVI are looking at this and I hope that they will give an answer on that pretty soon.
Thank you, Professor Whitty. I think it's probably quite shocking, given the statistics and what you've just said about the importance of women getting vaccinated, pregnant women getting vaccinated, that the JCVI hadn't prioritised pregnant women sooner. I just wanted to break down a little bit further. So the 22% is shockingly low, and it's even lower when you look at the statistics in ethnicity for Black, Asian, minority ethnic pregnant women. Is there any plans to really prioritise an education programme in terms of healthcare practitioners as well as pregnant women? And what is going to be done to increase that low vaccination rate for pregnant women as a whole? Do you know if there are any plans in the pipeline for it?
Yeah, so there's a really quite strong communications push. I'm acknowledging that this is not my area of expertise, but I've seen a lot of activity on this. And in a sense, there are two things intersecting on this. There's a really strong communications push to make sure that we are much more focused in making sure we get overall messages on vaccination through to people from every community in the UK, including ethnic minority communities. And that is essential. We need to keep on pushing on that. It's getting better overall, but it's nowhere near as good as it should be. And then there's a separate thing on pregnancy. And then within that, there's a separate thing on pregnancy in ethnic minority groups. And I know that individual practitioners, as well as particular places where there are high concentrations of ethnic minority groups, are doing everything they can to get this message home that vaccination in pregnancy is really important for the safety of mum and therefore for the long-term safety or long-term benefits of baby as well.
Thank you. And with the spread of Omicron, do you think pregnant women should be better supported to work from home or stay at home and financially supported if they cannot work from home?
Well, I think, I'm going to revert back to a point I made earlier, which is that's not really a medical question that I feel I have a particular expertise to say, except the general point that I would want pregnant women, of course, absolutely to be supported medically very strongly, of which the most important thing, I'll revert back to your first point, is the vaccination.
Okay, thank you. And I'll just move on to new variants. Is it time to move on from focusing on just our national vaccine statistics and more towards a global vaccination rates regarding the spread of and slowing the spread of new variants?
Well, I think I very strongly believe, and I'm very confident that everybody, both my fellow panelists and all of you on this committee, believe that we should be maximising the number of vaccines available in low and middle income countries. And that is, it's a humanitarian need. It's a need as fellow global citizens, and actually it's in enlightened self-interest as well, because this is a problem for everybody wherever there is an issue. So there's absolutely nothing to be lost and everything to be gained. Let me put a but on that. And the biggest but is that in Africa and the resource-poor parts of Asia, where I had the privilege to work for much of my early career, there are good vaccination systems for vaccinating children under 5, but there is not a system designed for vaccinating older adults, who are really the biggest priority everywhere in the world. And that is something, so we can't just say, here's a crate of vaccines, off you go. We've also got to look at delivery systems. So I think we need to see this as a whole system problem, not just as a product problem. But I do basically agree with the thrust of what you're saying. And I don't think that's controversial, incidentally. I think everybody would agree with that.
Thank you. Dr. Luke Evans.
Thank you, Chair. A couple of context-setting questions, if that's all right. Dr. Hopkins first. What's the current R value?
So the overall R value in the that was reported on the dashboard last week is between 1 and 1.2. However, it should be noted that there's 2 current variants circulating. One is Delta, which is remaining relatively stable in number, and the other is Omicron, which is increasing very rapidly. And with a doubling time of every 2 days, the R value for Omicron is estimated to be much higher. Very broad brush estimates of between 3 and 5 at the moment.
Thank you. And with regards to that, what is the absolute risk to those vaccinated and unvaccinated of Delta variant?
What do you mean by unvaccinated and vaccinated?
So for people, what's their risk of mortality for those who have Delta versus those vaccinated who've had 2 vaccines and those who had none?
So the vaccinated risk of Delta is the vaccine effectiveness reduces that risk of death by 95%. The absolute risk varies per age. If you are over the age of 70, it is extremely high. If you are under the age of 40, it is extremely low, less than 1 in 10,000. So the risk varies with age, and vaccine is the key to reducing that risk.
So very important to get vaccinated. Do we know the relative risk yet of Omicron with regards to vaccine and unvaccinated people?
Not for severity or for mortality. As I explained, we need to have a number of cases to be able to do that. We do know that the vaccine effectiveness to reduce symptomatic disease is lower for Omicron than it is for Delta. After 2 doses of Pfizer, for example, 8 weeks, more than 8 weeks later, your vaccine effectiveness for symptomatic disease in the community is about 40%. And once you've got boosted, that goes up to about 75% for Omicron.
Really helpful to get the context and why the boosters are so important. Turning that to Professor Whitty, you've talked at the start of the very first pandemic when we heard about it, about how the whole plan is population risk reduction. So washing your hands is easy to implement and has a big reduction. Mask wearing is the next level. Do you have a strategy on each of those implementations regarding how much risk it reduces? So do we know hand washing reduces by, say, 10%? Mask wearing 5%?
No, and I think the problem is there's lots of numbers on these bandied about. The problem actually is that really what you have is different combinations of things you can do, each one of which interacts differently with the others. So if you just take it in isolation, you would never say and randomize one group to have a face mask, another group to have hand washing, and another group to open the windows. What you're actually going to say in reality is do the whole lot, because these all build on one another, and they change. Different ones affect different bits of the risk. So the hand washing is about things you might pick up by touching because someone's coughed on a table or something, whereas opening the windows is particularly important for anything that's aerosol, for example. So I think what we would all say is all of these are moderate impact of things incrementally, but if you put them all together, much larger. But do all of them, because what they help do is they protect you against different elements of the risk, which are surrounding you: the droplet, the aerosol, the fomite on the table.
So, Professor Whitty, you've beaten me to it, because that's where I was going. Because I know it's for the ministers and the Prime Minister to decide what to do, but how is the data presented over which combination you put in place? For example, we could have chosen to have the rule of 6 return. We could have gone into tiers again. We could have actually closed clubs or pubs. How is it decided which constellation comes together?
Well, I think that in a sense, and I'm going to simplify what is obviously an extremely complicated and difficult process for ministers. But I mean, the first layer is, okay, what are the things that we can do that have no obvious downside socially or economically? Saying to someone, wash your hands, put a face mask on, open the windows when you can, has absolutely no downsides. Why would you not say it? So first question is, can we actually get through this just with those? Then there are some things which actually have a bit more impact socially and economically, and government has to take a view on that because they're having to balance things. Next level up is clearly things like advising working from home, as government has done. It's not in law, but it is in guidance, and things like you must wear a face mask rather than we would really like you to. And then obviously you then go up a ladder of intervention. Each step of the ladder adds some protection, but as you go up the ladder, the impact on society or the economy gets greater. And the difficult decision for the ministers is essentially how far up that ladder at any point in time should they decide to go. And that very much is the way I would conceptualize it.
That's very helpful. And now we've got the context of why the vaccines are so important. We've got the way in which you can deal with it for the general population. One of the biggest problems facing us in the future is the fact that there are about 10% of the population who currently aren't vaccinated. And the current first vaccine rate, to have your first vaccine, is about 20,000, 22,000 over a 7-day average. So we have a problem in society. How do we deal with the 10% or 5%, whatever it turns out to be, of people who won't get vaccinated, given all the context you've given to all the other questions, and now we know about the importance of the vaccine, but for those 5 to 10%, medically, what is your sort of response of how we could deal with that? What are the options that you would present in front of government?
Yeah, critical question. So I think there's a very small number of people, and they're very noisy, but they are very small, who basically, due to weird conspiracy theories and all sorts, are just simply never going to get vaccinated. And except where they work in places where there are lots of vulnerable people, the view of government is fine. You just got to accept that. But of the 10%, a very large portion of those just haven't got round to it. And that's really the people you're addressing your question to, in a sense. And I think that there are basically 4 things people want to know, and that we have to do and make sure are culturally relevant as well. And that doesn't just mean ethnically, culturally. I mean, making sure every bit in society feels that we're talking directly to them in a way that they feel comfortable with and trusting of. First thing is they want to know that the disease is a big enough threat that it's actually worth doing anything at all. That's a really critical thing. Secondly, they want to know that the vaccines actually work. And on both of those, we have incredibly good evidence. We know that this is a big threat, and we know that the vaccines do work. The third thing is they'd want to know that the side effects are proportionate to the benefit that the vaccine's giving them. That one we have to keep on going at, because there are huge numbers of myths out there. These are not people who believe them who are anti-vaxxers. The anti-vaxxers start them, but they're not. But the people who believe them, they just read something on the internet, they're worried, and they need to have serious information put to them. And the final thing is we need to make it convenient. Convenience makes a very big difference. I found it very striking when I was last on the wards that the people who I spoke to who not had vaccines, who were disproportionately there, unsurprisingly, an awful lot of them said, I hadn't got round to it yet. It wasn't that there were a few of them you'd meet who just believed all sorts of nonsense. But the great majority, it was I hadn't got round to it yet. And it's that combination of making sure that their fears are correctly and politely and scientifically addressed, and we make it as convenient for them as possible. And my hope is that this huge boosting campaign that's going on at the moment also gives people an opportunity who've not had their first vaccine or haven't had their second one to come back and actually say, look, the threat has gone up again. Now is a really good time to get my first or second vaccine, and obviously for everybody else to get a booster.
That's really helpful. My final question is to Dr. Waite. One of the things the CMOs have agreed is to suspend the 15-minute wait post-Pfizer for boosters. Are there any other things that you are looking at that may well help the throughput, given how important we've just heard it is to get those boosters, given that convenience seems to be the main thing? What is government looking at doing practically from your position that may well make a difference to making the booster programme as successful as possible?
Thanks, Dr. Evans. I mean, you've touched on one of the really key things there, which is that by suspending the 15-minute wait, you can get an awful lot more patients through any given clinic. That applies not just to the very large vaccine centres, but also I've had the privilege of working in quite a few community pharmacies during the booster campaign. It makes a real difference there because there's really only a limited number of places that people can sit to wait. So that's a great big plus one. I'm not on the operational side of the vaccine programme or planning it, but there are 2 key things from that I think I want to draw attention to. The first is opening extra very large booster centres. I know that Wembley will be open this weekend. I think the Chelsea Stadium will also be open. Those will help to get sort of numbers up, to get throughput. The next, though, and I think this is quite important for the points that Professor Whitty was just making, is the much smaller centres, the much more convenient centres, the places that people trust. During the primary campaign, I was lucky to work with a GP in West London who had opened a vaccine centre in a community centre as part of the mosque, going to places that people trust, seeing people who are community leaders being part of the planning of the vaccine programme for their community will also not only help to increase the number of slots available, but increase the ability for people to be able to get to a vaccine centre that feels relevant to them.
Thank you. Laura Trott.
Thank you, Chair. Professor Whitty, I just want to go into a bit more detail from the Chair's questions at the outset about the link between case numbers and hospitalisations. Obviously, with the vaccines, we hope we've broken that link to a very large extent between cases and hospitalisations. So can you just take us through where we think we are in terms of the percentage of hospitalisations we expect from Omicron and how that differs from Delta?
Thank you. So, I mean, the very short version of that is we don't yet know, unfortunately. I'm going to make an assumption, which I think is safe now, that that naturally Omicron is not more dangerous than Delta. It may be milder, slightly milder, it may be the same, we don't know. This is before vaccination, but let's assume it's roughly the same. Now, if we compare where we were, let's say, with the last big wave, not the Delta wave we just previously had, but the one before that, the infection hospitalization rate for people 65 or over, for that wave, prior to the vaccination program, was about 22%. So 22% of people, older people who got infected would end up in hospital. After 2 doses in big vaccination program, accepting the last points that some people didn't get vaccinated, but overall, that dropped to 6%. So 6% of people who were infected ended up in hospital, over 65, much lower in younger people, to be clear. I'm just talking about older people here. Now, the question with Omicron is, firstly, is it intrinsically milder? And I don't think there's clear evidence that says it is actually at this point in time. There are correctly reports that there are low hospitalizations in South Africa in the last wave, but I'm not sure that guarantees it's milder. It may be, we don't know, but that's one possible question. And then the second question is, after you've had 2 doses of vaccine and then 3 doses with the booster, what percentage does it reduce its severity compared to what it would have been? And is that as good as Delta? It's unlikely it's going to be better than Delta because it's less well matched. But let's say, is it as good as Delta for severe disease, despite not being so good for infection, or is there some reduction in that severity? And that really is the key question on what's going to happen for the health service as a whole, what happens over the next period. So I think it's really critical that we wait for those data before we jump into saying this is what's going to happen. But the worst that would happen would, in my view, would be where we were back in the Alpha wave earlier this year. And I think the top end of expectations would be probably for 2 vaccines, be where we are from the 6% with Delta. But it is possible that with a boost, we're better off with Omicron than we are with 2 vaccines with Delta for severe disease. I don't think that's likely for infection, but it's possible. But we honestly don't know. The range of possibilities is really quite wide, and that's why it's very difficult to make definitive views about where the NHS is going to end up in the next 4 weeks.
But unless we have a significant change in terms of the hospitalisation rate, with the type of numbers that we're talking about here with Omicron infections, we're looking at some very serious hospital admissions. Is that fair to say?
Yes, I think unless things all fall, so of the things that we know about, most of them so far have not fallen our way. This has got lots of antibody changes. At least one of the drugs we've lost. We know that it's less effective on infection, but some critical things we don't know, like severity, we don't yet know for sure. We know it's not trivial, but beyond that we don't know. And on the effects of boosted vaccines, we don't know. If they all fall our way, the numbers will be less concerning. If they don't all fall our way, and so far we've not been lucky in COVID, so I think planning on the basis they will, then the numbers in hospital over a short period could be very high indeed, potentially. And that the big issue here is they're all going to come in a very concentrated time. This is back to the Chair's original set of questions. You know, the same number spread over 3 months might be something which is much easier for the NHS to handle than the numbers we might see over a very short period of time. So that's really a very big issue. And I'm afraid if I can add an additional point, which I think people have just got to realise, is that this will also be happening at a time when a very significant number of staff are going to be off ill, isolating or caring. So you're going to have both a reduction in supply and an increase in demand in the health service over a very short time period. And that really is the reason why we're all taking this extremely seriously.
And in terms of hospital-acquired infections, which we know has been significant throughout the process of this disease. What more can we do on that front? Because this obviously is even more, well, seems to be even more infectious than previous waves that we've seen.
Yeah, we have got a problem here on infection control. I mean, we've learned a lot, and I think the infection control is much better than it was because we've learned as we've gone through. But two things, unfortunately, are going to go against us. This is more infectious than previous ones. It just seems to have an extraordinary intrinsic ability to infect, and that's going to make it harder. And then one of the mainstays of our approach was vaccination. Now, boosted vaccination will reduce transmission, but it's not going to probably take it right down to where it would have been with boosted vaccination against Delta. So I think we will do everything we can within the health service, but I think we can't claim we will get away scot-free on this. Even with really good, rigorous approaches to this, there will be hospital outbreaks and other health and social care outbreaks. We will do everything we can to minimise them, but I don't want to set people up to fail by saying, no, we won't have any. We will have some, unfortunately, because of these two factors.
Thank you, Professor Whitty.
Thank you. Greg Clark.
Thank you very much indeed, Chair. Professor Whitty, if we reflect back on the last 20 months, we've taken different approaches, understandably, to trying to suppress the spread of the virus. We've had very significant lockdowns. We've had regional tiers, we've had detailed specific restrictions. In the last 10 days, the Prime Minister has urged people to get boosted, and we see queues around the block. You have said, and you've repeated it today, that people should prioritise their social contacts, and we know that they're already doing that. People are withdrawing from some events. Have we reached, and are we in a phase in which broad advice, rather than detailed, I think as you put it, should do this, shouldn't do that, restrictions on people, is that where we are? Is that the right way to be thinking about this now?
Is where we are now, but if we were in a situation where, for example, it looked as if the boosters were not going to be as effective against severe disease and transmission, and we were facing the kind of situation that we were talking about in the last exchange, then ministers are clearly going to have to consider what else needs to be done. And I'll go back to this concept. It's a very standard public health concept of the ladder of intervention. How far you go up that, and the further you go up it, the more damage you're going to do in other areas. And ministers fully have to balance these. This is very much their prerogative, and that of obviously Parliament. But balancing those, the bigger the threat, the further up you probably were going to have to go. And so what we are is ministers have made decisions based on what we know at the moment. If the information that comes in is reassuring, that will tend towards one direction. If the information that comes in is distinctly not reassuring, that will tend to another. And that very much is, I think, the way the Prime Minister and ministers are looking at this.
Well, let's consider the optimistic side of this, and we get through Omicron perhaps quicker than we might have thought, and that the spike happens and we come down it quickly. What would trigger the exit from the current set of restrictions and the advice that you and others are giving?
Well, I think we've seen before and most recently in summer of this year, a very clear de-escalation of advice, even though at that stage there was still some residual risk, and we accepted that, and we've talked through the logic of that, and some people criticised that. But that was the decision of ministers, and there was perfectly sensible scientific logic that made that a reasonable thing to do. There were alternative paths, but they chose that one. So ministers are always in a position where they can go up and down as the facts change, and that very much is the way that the approach the ministers have perfectly sensibly taken. And as we got on, but I am really cautious, to go back to the stem of your question, about making policy on the basis that everything might go right. That is not, in my view, a sensible basis on which to make decisions.
Indeed,
I think you should make decisions based on the range of possibilities rather than just assuming everything's going to fall my way from here on in. I think I should always be cautious of that.
Indeed, and that's not the implication of my question. It's to consider the scenario which hopefully at some point will happen in which we can de-escalate. And The question is, what is likely to trigger that? Is it a fall in the prevalence rates, fall in infections? Is it reaching a certain level of boosters in the population? Is it knowledge based on evidence of the severity of Omicron? What is likely to trigger such a reconsideration?
So I think that there are multiple exit points, and they really depend on what happens next. It's a very sensible and good question. It could be, if absolutely every bit of news that came in from here on in, we discover that actually with boosting and double vaccination and a milder variant, actually this is just not going to, we can de-escalate really quite quickly. This isn't going to cause a big threat. An alternative scenario is that it could be a very sharp wave, but the wave decreases quite quickly afterwards. So there have to be significant problems, but for a relatively time-bound period. There could, at the other end, but there is an exit, it's a longer exit, be a situation where actually it's not until you've got an Omicron-specific vaccine, which somewhere, based on what the manufacturers say, between 4 and 5 months, and that's the exit strategy. But I think there's so many unknowns at the moment than saying which of these kinds of exit strategies. I am very confident, as you have implied, that there will be an exit strategy. When it will be and how quickly we will reach it depends on a lot of factors we currently don't know, and that fundamentally is really where we are at this point in time.
Will you have the agility to de-escalate if the results of the various factors that you've mentioned go in the right direction? Will you be able to intervene and stand down your advice to minimise social contacts, for example, to advise that the Plan B restrictions should be stood down before the time that they expire at the end of January? Are you set up to do that?
Well, be really clear, because I think you know this, but I just want to be clear for the record. Decisions on anything that involves those kind of decisions are for ministers, not for me. I will give the scientific advice. SAGE gives scientific advice formally with the government chief scientific advisor, and we give data. Ministers take decisions. In terms of my own advice, I have put more stringent advice, in a sense, advice to the general public because of Omicron. We had less stringent advice before Omicron arrived. It's not, the public want us to keep them safe, and they want us not to, at the same time, over-egg it at a point where it looks as if things are getting back to a more normal situation. Of course, people will turn up the dial and turn down the dial as necessary, and of course there are people in government, rightly, who are arguing for the very strong economic implications of doing anything more than we need to, and it's always about balance. All the way through this is about balance in terms of the advice in both directions.
You are giving advice directly to the public, and I don't necessarily criticise that. People are interested in your views, and I think respect your experience and judgment on this. You have said you've advised people to prioritise their social contacts. That is advice that you're giving directly. Generally, in the past, you've made the point to my committee that you advise on sort of the medical aspects, and then ministers have to weigh in the balance the consequences for society, for the economy, and come up with recommendations that brings the medical advice with these further consequences together. If you're giving advice direct to the public, then that process is not taking place, is it? And therefore, how do you ensure that it's not one-sided advice? And to go back to my point, are you prepared to have the agility to adjust your advice that's out there if, as we hope, eventually it will be appropriate to do so?
I am extremely clear on what I think the role of an advisor is, an independent advisor, and what I consider the very paramount role of ministers is. But there has always been, from the very beginning, the very first chief medical officer in the 1850s, chief medical officers have always given advice to the general public, but ministers reserved to themselves, rightly, anything to do with the law, anything to do with balancing against the economy. This is advice that I think any Chief Medical Officer would have given, and I don't actually think that any minister is feeling I'm treading on their toes on this one. This is my job. But I also consider that questions about things like further measures, those are very much for ministers. So it's drawing the line between those two. The expectation is the Chief Medical Officer and medical advisors will talk as a doctor independently and give advice as long as they don't stray beyond into the job that is specifically for ministers.
Thank you, Professor Whitty. Thank you.
Thank you. Just one very final question from me, Professor Whitty, about that advice that you've been giving over the last day and the issue of compliance with it. Isn't the fundamental problem that people personally feel safer now if they've had 2 or 3 jabs, but the NHS is actually more at risk, or potentially more at risk, because of the nature of Omicron and the fact we have 4 million or so unvaccinated? How do you persuade people who've had 3 jabs to be more cautious?
I started the whole pandemic with very high confidence in the British public's ability to perceive risk and make really sensible collective judgments, and that has only strengthened over time. So actually my experience has been all the way through, and what people do demonstrates this, and indeed polling demonstrates this. People take these things very seriously. They accept that if they have had 3 doses of booster, they are at lower risk, but people will still take sensible precautions. And I'm very confident in people's ability to say, look, for the benefit of everyone around me, for the older people who I come into contact with, for all of these things, I'm going to be more cautious. Over a period, these numbers are clearly going up very, very fast. And in answer, in a sense, to both of your questions, it would be very odd to reduce that advice at a time when the numbers are spiralling up. The time to start considering whether you should be reducing is when the numbers are starting reasonably consistently to come down. People look at those data and they think, look, I want to reduce the risk for everyone around me and for my family and for myself, and I'm just going to take sensible precautions at this point in time. Sensible and proportionate precautions.
Thank you. Well, Professor Whitty, Dr. Hopkins, Dr. Waite, you've been very generous with your time. We appreciate you coming this morning, wishing you all a safe and happy Christmas. Thank you very much indeed. Order, order.
Thank you very much.
The proceeding has ended. 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 The proceeding has ended.